Hi guys, here is your how to survive for your hypersensitivity CBCL. So first, let's go through the self-study table of contents. So hypersensitivity basically means any immune response that is happening overexuberantly and inappropriately. So asthma, allergy, those are certainly considered hypersensitivity. Allergy more than asthma. In fact, allergy is a type 1 hypersensitivity. The other hypersensitivities all pretty much refer to either autoimmune disease or transplant rejection. And so this packet is largely going to focus on autoimmune diseases and transplant immunology. You'll note there's not very many videos, and the videos that are pretty short. So these videos, the type 1, type 2, type 3, and type 4 hypersensitivity videos are videos that I made not last summer, but the summer before with osmosis. So the cartoons are way better. The detail is a little bit less, but I do think it's enough to kind of help you wrap your mind around hypersensitivity in conjunction with the notes. If you go through the notes and those videos, which are fairly short, and go, I still really don't understand hypersensitivity and I want another more detailed video, that's fine. Email me. I'll make more videos. It's not a big deal. But I thought we'd try it this way first because I have heard student comment of kind of being overwhelmed by the amount of material and matching material. So I thought we'd try this kind of overview method this time. There is also this one video about agglutination versus precipitation. This is an important concept that you kind of need to know. It's something boards like to trip you up on, and my predecessor, Tom Lint, does it in fantastic fashion in this 3-minute video. So make sure you check that out. Okay, pathology, no videos for you this time, and no outside links. Dr. Poole writes a fairly short course note that takes you through the pathology behind the 4 types of hypersensitivity. Okay, histology. There is no histology in this packet, but Dr. Al Ghul provided you with a couple of study questions to help you get through some of the material from your skin lab that you maybe didn't get to really spend much time on during the skin lab. So check those out. It won't be on your readiness assessment and it won't be in the CBCL, but this was just kind of a place I could put it where I could draw your attention to it. It's designed to help you begin studying for your summative if you haven't already. And then you have your study questions. Okay, so let's go through the actual packet. First off, the hypersensitivity vignettes. We're going to do this a little differently than we've done some of the other cases. So you're not going to be given the case in advance. You're going to be given the cases when you walk into the room. There are 4 different cases, and they're not quite as long as like a standard CBCL cases, but they're also not as short as a standard CBCL vignette. They're somewhere in between. And the idea is that you'll be able to read through these and kind of from the problem cues, be able to figure out which type of hypersensitivity each patient is suffering from. So the first thing I do is give you kind of an overview on hypersensitivity and the 4 different types. So type 1 really just refers to allergies. So that's Th2, IgE, antibody, mast cell, and eosinophil mediated. Type 2 is what we call the cytotoxic hypersensitivities. So in this case, you have IgM or IgG antibodies that are binding to a cell surface and often leading to the killing of that cell, typically by complement. It's often complement mediated. And occasionally we'll see a non-cytotoxic type 2 hypersensitivity where it basically blocks the ability of the cell to function as it should. So those are the 2 types of type 2 hypersensitivity. You've got cytotoxic and non-cytotoxic. All right, then you have type 3. Type 3 is basically when you still have antibodies, but now you have immune complexes. So like here, you've got one antibody, an antigen, and then another antibody. They're forming this nice little triad complex. If the triad complex deposits somewhere, it's going to cause inflammation in that location. That inflammation can be really damaging to the body, and that's known as type 3. This is what we associate with like lupus or rheumatoid arthritis. And then there's type 4. Type 4 is mediated by T cells. So I often remember it by going type 4 is mediated by CD4. But it can also be mediated by CD8, but it kind of puts me on that T cell track. And in this case, you basically have cytokine-mediated inflammation or direct lysis of important cell types within a tissue that are mediating disease. This is one of the ways that multiple sclerosis is mediated. Okay, so I give you some mnemonics. One of the ways to remember them is acid, allergy, cytotoxic, immune complex, and delayed. And then hopefully you can just remember that there are a couple that are not cytotoxic. We go through some of the general mechanisms. Why do people get autoimmunity? And then this is actually something almost directly out from your step 1 book. So there are certain HLA subtypes that are more associated with certain diseases. And that's one of the genetic components that plays a role in why people develop autoimmune disease. So you can see that certain subtypes have a certain predilection for certain immune diseases. So HLA-DR2 is associated with multiple sclerosis, lupus, Goodpasture's, and allergies. These are diseases we more often see in patients of European descent. HLA-D3, Graves' lupus, and type 1. HLA-DQ, DQ2, and DQ8 are associated with celiac disease. I think I put it in here, but a mnemonic for celiac disease is I ate too much at the DQ. So I ate too much at the DQ for remembering your HLA for celiac disease. Celiac disease is kind of a misnomer for me. It's currently classified as a hypersensitivity. I consider it more of a intolerance, but we can talk about the genetic components that go along with it when we get to your CBCL session. And this is something that will come up again later in the curriculum. There's a specific classification for how these diseases are broken down into 1, 2, 3, and 4, which you can go through here. And then I go more in depth on each of them. So this is type 1 hypersensitivity. Some of this should be really, really familiar from your Nicole McNeil case. In fact, a lot of it should be really, really familiar from your Nicole McNeil case. So I put it in here, but you should be able to kind of breeze through this one, having read it before, specifically the mast cell mediators portion and atopic march. So all of this should be really familiar for you to be able to go through pretty quickly and go, yep, I remember this from foundations. Okay, then we go into a different classification system. So there's systemic, and then there's tissue-specific autoimmune disease. So systemic is something that it's affecting your whole body. Tissue-specific may have effects in your whole body, but the inflammation is localized to one place, okay? So how do we explain this? Well, the best way to kind of look at this is systemic autoimmune diseases that are non-organ specific. So this would include things like lupus, where really we're getting antibodies to DNA, and you have DNA everywhere in your body. So anytime an antibody binds some DNA, it can deposit somewhere, and it's going to cause different effects depending on where the antibodies deposit. Whereas diabetes is an autoimmune disease that certainly affects your body, but the inflammation is localized to the pancreas. So we go into a couple of those. You'll see that I have these tables here. Anytime I have these tables, these are important. I want to be able to ask you, what is the target of ATP, autoimmune thrombocytopenic purpura? And I want to know what the consequence is. You need to know these tables cold. And then I go into some of the manifestations of disease. Graves' disease and myasthenia gravis are the two best examples of those non-toxic type 2 hypersensitivities. So in this case, the antibody binds to a tissue receptor, which basically makes the organ dysfunction. And that's what's occurring here. So go through those, understand that. Then we go into blood group antigens. And the reason we go into blood group antigens is that many of the hemolytic anemias are actually a result of a type 2 hypersensitivity. It's a reaction we didn't want to happen that led to the lysis of red blood cells. So it's a good place to introduce the concept of red blood cells and how antibodies might bind to them. So this goes into the different types. We've got 3 types of blood, A, B, and O, and they're all based on a common carbohydrate structure, which is what's shown in O. But then A and B have different side chains, so that changes what carbohydrates are available. So then you can see which type of antibodies people will make based on how tolerant they are. So this goes back to the central tolerance that occurs with B cells, right? Because since these are carbohydrates, we're only talking about IgM antibodies here. So go through this and understand how that works. Now, What do we mean by that positive and negative? Positive and negative really is the Rh factor, the rhesus protein factor. And this is a protein. So if it's a protein, now we're talking IgG. So you can have IgM antibodies to the actual blood group, but then you have IgG antibodies to the positive or negative, whether or not you express rhesus protein. So for example, I'm O positive. So I have the base carbohydrate. I do not have rhesus protein. So I'm like this. My husband is type A, so he has the A carbohydrate, and he's also positive, so he has A positive blood. So we both express the rhesus protein. Okay, so we go into how you can use these designations to not only make blood transfusions, but also how it affects newborns. So for instance, if you have a mother who has negative blood and a father who has positive blood, the first time around, babies are all going to be fine. The second time around, though, mom might have some antibodies to the IgG or to the rhesus protein, some IgG antibodies. And remember, IgG can go across the placenta. So that basically leads to a phenomenon we know as hemolytic disease of the newborn, or erythroblastosis fetalis. It's not always fatal. Sometimes the baby just needs some help breaking down those red blood cells they lysed, and they get a nice little tanning booth here. And we actually have a prophylactic treatment for it. So if we type mom and we type dad and we know what's going on, it's not a problem. Okay, then we have agglutination tests. This is actually how we test if somebody has antibodies in their blood that are going to bind to red blood cells and potentially cause a problem, or are already bound to red blood cells and causing a problem. So if they're already bound to the red blood cells, that's a direct antibody test. If they could bind to the red blood cells, that's an indirect test. So go through these, come up with some situations where you might use them, why they might be important, because that'll make you better able to understand how these tests are actually used clinically. And I give you kind of a pictorial here that I think explains it really well as to how we could use these. And then Dr. Hartley wrote this clinical example of how we could see this in a neonate, okay? All right, then we go into agglutination versus precipitation. Watch the little video from Tom Lint, go through this information, and understand that pretty much anytime we're talking about a particular antigen, which is really red blood cells or latex beads, it's agglutination. If we're talking about any other antigen, it's precipitation. Okay, and then we go into more hypersensitivities, because now we've kind of laid the groundwork. So autoimmune hemolytic anemia, that's a type 2 hypersensitivity. ITP, autoimmune idiopathic thrombocytopenic purpura. This is what we were talking about in some of the CBCL sessions for Cameron Thompson Part 2, that you can make antibodies to your platelets that attack your platelets, and that obviously is a problem for clotting. So we go through these. Remember that Graves and myasthenia gravis are non-cytotoxic, but the rest of these, once again, this is one of those tables. I want you to know the target, I want you to know the manifestation, I want you to know the name, okay? All right, type 3. This is that systemic. One of the main things with this is that we actually see depletion of complement, because it's working at complement, but it's kind of working so hard to destroy an entire, to create inflammation throughout the entire body, that complement actually gets decreased. And that's one of the ways clinically we can identify it. So that's one reason why I made you know complement. So you can go through this. Lupus is kind of the big prototypical disease for type 3 autoimmune disease. And you can go through kind of the presentation of lupus there. Okay, and then lastly, we do type 4 hypersensitivity. Type 4 hypersensitivity is T-cell mediated. I give you a couple options. Here's a multiple sclerosis video that myself and Dr. Hepner, one of our neuroscientists, wrote with osmosis last summer. That'll take you through kind of how that works. It's more detailed than you need to know for now, but if you focus on the immune-mediated portion of it, it'll actually fill in some of the gaps on type 4. And then here's another one of those tables that you just gotta know. This one is something that I want you to pay attention to. So contact sensitivity is a type for response, okay? So an example of this is poison ivy. This basically is produced to a toxin on the plant, but not a self-antigen, but you still are responding inappropriately, and you get this inflammation. I actually get a minor contact hypersensitivity to metal. If metal gets wet on my wrist, like sometimes I'll have a minor contact hypersensitivity as a result of a minor metal reaction. And that's pretty common. That's another form of contact hypersensitivity. And then something you learned about in Cameron-Thompson Part 3 was the PPD test that we use to determine whether or not a patient has ever been exposed to tuberculosis. Well, this is actually taking advantage of the body's own hypersensitivity response. This is one of the few times where we don't want to see a response, but it tells us that a patient has had PPD. And really what it's doing is it's priming T cells to see what the interferon gamma response to the purified protein derivative from tuberculosis is. So those are your examples. And then the last one is actually a transplant example, and that's graft versus host disease. And then we move right into transplant immunology. Like I said, I think this is pretty simple, so I just wrote kind of a simple course note up on it. We'll do a little bit on it in your CBCL. Important notes here to keep an eye on are the 4 different types of transplant you can get, and then the different types of rejection you can get. Okay, so you can have hyperacute, which basically means that you had preformed antibodies to the donor in your system. So if you're the recipient and you're receiving an organ, you had antibodies that were specific for that donor, and within minutes of you receiving that organ, your antibodies attacked it, and that led to the failure of the graft. This can happen minutes to hours, up to 24 hours. Then acute rejection starts after that, and you can have direct, which is a T cell, or indirect, which leads to priming of T cells. So this can happen, within a couple of days. These are often reversible. We can just suppress your immune response and it'll be okay. Then you can have chronic rejection, and this happens slowly over the course of weeks to months, and this will eventually lead to loss of the graft over time. And then the other one is kind of the flip side of the coin. So in all of these, the recipient is attacking the donor organ. Graft versus host disease means what it says. In this case, the graft is attacking the host. And the most common way this happens is with bone marrow transplants. And if you think about that, that makes sense. Your bone marrow is chock full of precursors for the immune response. It's chock full of your army recruits. So as they get activated, they go out in your body and they attack. So we talk about that, and then we talk about HLA matching. I won't ask you to match HLAs necessarily early on. We'll talk about it in your CBCL, and then I might expect you to match them. But I do expect you to know certain examples that we have to know how to match. So for example, what are reasons that people might reject? So you can get hyperacute rejection in solid organ transplants. And you need to kind of understand how that can happen to both the major histocompatibility organs and the minor histocompatibility antigens, okay? And use your self-study questions for that. I think it'll help a lot. Okay, here's Dr. Poole's session. He just wrote you some notes. So go through each of them. It talks about the type 1 hypersensitivity, the immediate reaction, and the late phase reaction. Again, you should be somewhat familiar with some of what those terms mean from foundations. If not, I've placed all the material in this self-study for you. He gives you some images, and you can kind of page through them and see the descriptions. Same with type 2 hypersensitivity. He talks about the different cell types that you should be able to recognize, different types of inflammation and dysfunction that you might see. And then type 3, here's type 3, and he gives you an example of vasculitis here. And then here's type 4, and here you're actually seeing the destruction and the granulomatous inflammation that's associated with the T cell activation. And that's it. That's the entirety of the self-study. So here are your study questions, and good luck. Let me know if there's anything you need.